everybody. It's Dr. Scorbert. It is Wednesday, 18th. So this is following our class yesterday on Tuesday when we started the beginning discussions of how the nursing process generates the clinical decision-making model and how we can actually implement it within the care. And so I guess part of my reflection of that particular component of the lecture yesterday, I just felt I wanted to reorganize, not change any of the content, but reorganize the presentation in the sense of how to look at it in a more structured format. I just felt I was a little disjointed coming out of the gate, so I really just kind of want to bring it back in a way that when you are muscle memory training your mind to think about specifically how to layer out components of this process, this overview might be helpful for you. So I want you to start with the concept. So when you look at the concept of elimination, I want you to be able to define the anatomy. So the example is going to be the renal system. So know which is considered the upper portion of the renal system and what is the lower portion. That's the anatomy side. Then I want you to be able to define the physiology. What is considered normal function of the kidneys, glomerular filtration rate, evidenced by BUN and creatinine within normal limits to support that the kidneys are functioning appropriately. The ureters used to transport urine to the bladder, and the bladder is your reservoir. Also know that it has a capacity, sensors that signals to the brain for mictration or elimination to go pee, void, whatever language you want to use. Urethra, length of the urethra for the voiding process. Again, come back to women have shorter urethras, men have longer, increased risk of UTI. Bottom line is that when you get to the concept, I want you to be able to do note cards or whatever it is that you learn best, however your learning style for you is. Talk it out loud, walk around, dance, note cards, whatever your process is. Start with the concept. Start with what is normal A and P. All right. Know what the system's for. What that does is it drives your baseline of normal. So when we start talking abnormal, like BPH, renal calculi, erectile dysfunction, for example, those have implications. Skip the erectile dysfunction. BPH and renal calculi as it relates to elimination, because when you start talking abnormal, you already know what normal is. So know your concept before coming into class. Etiologies. We have to know what the etiology is. So, you know, the concept of elimination. Okay, well, the etiology, for example, of BPH, bring it down. It's males, typically over the age of 60. Just have a generalized understanding that you wouldn't expect a 20-year-old male to come into the ED with difficulty urinating and stand there and think it's BPH. So having an etiology understanding helps that clinical decision making that the 20-year-old most likely isn't having a BPH issue. Okay, could be an STD. See where I'm going with the tracking. Renal calculi, same thing, same principle. Recognize modifiable versus non-modifiable. Recognize that non-modifiable family history is going to increase risk factors. These are already in your PowerPoint slides, which is your groundwork coming in. But I will say the word as studying for exams, but more importantly for the safety of your patient population at the bedside clinically, when you know the etiologies, it helps narrow down how you work out clinically what's going on with your patient. So again, note cards, walk around, sing it, dance it, whatever works for you to have it stick. So concept, A and P, etiologies. Then you're going to go into the clinical manifestations, okay? You want to know how that patient could present. Remember, your Pearsons and your ATI are foundations. Your patients are always individual. They could always present a bit differently. They could be complete outliers, etc., etc. But your textbook does provide a consistent overview of what we know research-wise will support a clinical manifestation of a patient who presents with BPH, a patient who presents with renal calculi, okay? So know your clinical manifestations on what you can anticipate then, hallway thoughts, when you walk into that patient's room, what that physical assessment is going to look like, what you anticipate those vital signs to look at. That's going to start driving your thought process for objective data as it relates to your head-to-toe assessment, your set of vital signs, and then you're driving your focused assessment, which is objective data collection from your hands-on, your inspection, the use of your stethoscope, whatever the case may be, as it relates to that clinical manifestation. And that incorporates subjective data to drive more of those Q&As and the history collection, okay? Within the assessments, you have the assessments needed for a patient for renal calculi. What do you expect that patient's going to say, to feel, to complain about? What objective data from that is going to drive those clinical decisions? What do you expect the doctor to order? What do you expect you're going to have to do to intervene? All right. What expected comments and verbalization from the patient subjectively? Again, what do you think he or she is going to say? Those cues, those are what you recognize. That's what you hypothesize is going to happen with your assessments because you understand the etiology of renal calculi. You know what the clinical manifestations are going to be. That's going to drive what you're going to do with the patient. All right, that drives your care, that drives your interventions, and that's where we begin prioritizing based on the patient's presentation what we're going to do first, what becomes a priority. Okay, renal calculi obstruction, okay, of the normal physiology of the elimination system. We want to reduce the obstruction. We want to improve urination. We want to reduce symptomatology of pain, which is going to help facilitate improvement in vital signs in pain management. Just top three right out of the gate, right? Not easy, but you'll get there, okay? We have to always evaluate your patient responses. Always have, doesn't matter if they move their bowels, taking milk of magnesia. We have to go back and evaluate the effectiveness of our treatments, interventions, treatments, hands-on, administration of, this all encompassing what we do to our patient. But you have to have the concept down, you have to understand the etiology, you got to know the clinical manifestations because that drives everything from that point forward, what you do, what your orders should include, what you expect the orders to look like. Okay, if the order isn't there, you know what should be there. Okay. Labs, renal calculi, we talked about it yesterday. I want kidney function, I want BUN, I want creatinine, I want potassium level, I want sodium level, I want a blood pressure. Okay, I'll get everything else with it, but my focus points is going to be on lab specific to the functionality of the renal system. Okay, BPH, all the above, but I want a PSA. Maybe I'll add a digital rectal exam to confirm that the prostate's enlarged from a palpation standpoint, or all right, treatment specific to the disease. Cannot forget wellness, cannot forget health, cannot forget education, cannot affect mental health related to chronicity, support systems, community resources, all of those psychosocial, financial, stress, definition of health as it relates to your patient has to be encompassed within that plan of care so that we have a holistic approach and not just, pardon the expression, hands-on bedside care. We need the big picture, okay? So everything I just said drives that clinical decision making where you prioritize what you're going to do first, second, and third. All right, that's the clinical decision making. The cues, the hypothesis, put it in motion, do it, and evaluate it. Did it work? Did it not work? If it worked, super. If it didn't work, what are we going to go back and recognize differently? What are we going to do differently? That's the evaluation. All right. What I'm giving you is not written in stone, but again, when I evaluated and reflected yesterday, I do feel that I could have come out of the gate with a more structured approach. All right, so when we start talking care plans, case studies, case scenarios, we're going to drive it from this point. So I'm going to expect you to come to class like you did yesterday, all right, and you will continue to do so. You know the normal concept, you know the A and P, all right, you know the clinical manifestations, you know the etiologies. We will drive the assessments and the plan of care based on our patient presentation within our scenarios in class, all right. And never forget to lose sight of Maslow. Obviously, we can't climb up the pyramid unless we have ABCs in order, okay? That's it. That's what I got. I'm going to put this up and I'll put out a message, email, announcement, all that fun jazz. If you have any questions, just shoot me an email. We're off to still to a great start. I'm just my worst critic, and I really felt that I could have brought this point home better. So here you go. Have a great evening and a great week. And I'll see you all in clinicals.